Good afternoon, everyone. My name is Simran Chaudhary. On behalf of Voice of Healthcare, I welcome you all to this special panel discussion on World Hypertension Day 2025. Our theme for today is Silent but Deadly. Understanding and combating hypertension in India reflects a growing national concern. Hypertension, often called the silent killers, remains one of the India's leading yet underdiagnosed and underrated health threat. Through this discussion, we aim to raise awareness and explore challenges and drive meaningful conversation around prevention, early detection, and long term management. And for this important discussion, we are privileged to be joined by four eminent experts, each bringing a unique perspective to today's conversation. Dr. S. N. Narasingan, Vice President of Hypertension League and Vice Chairman of the Lipid Association of India. Welcome to our show, sir. It's a pleasure to have you here.
Yes,
Thank you so much, sir. Dr.
thank
C. H. Vasanth Kumar, President of Indian Society of Hypertension and Senior Consultant, Department of Internal Medicine and Geriatrics at Apollo Hospitals, Hyderabad. Welcome, Dr. Vasanth.
Thank you for having me.
Thank you so much. It's a pleasure to have you here. Dr. P. Ganeshkumar, Scientist E and Head of Division of Non-Communicable Diseases at ICMR-National Institute of Epidemiology. Welcome, Dr. Ganeshkumar.
It's a pleasure to be having in this panel.
Thank you so much. It's a pleasure having you. Dr. Jagmeet Madan, Principal of Sir Vithladas Tharkare's College of Home Sciences and National Vice President of Indian Dietetics Association. Welcome, Dr. Jagmeet.
Yeah, thank you for the invitation, and it's a pleasure to be here. I stand corrected. Uh, I am the National President of Indian Dietary Association, and I am also a professor and director, Research Innovation Collaboration Center of Sir Das Thakur's College of Home Science, which is an empowered autonomous status college of SNPT Women's University, Mumbai.
Thank you so much for that correction, ma'am, and thank you for being in the panel discussion. It's a pleasure having you. So, with this, we'll begin today's discussion, and I would request Dr. S.N. Narasingan to share his opening remarks. So, as the Vice President of World Hypertension League and Vice Chairman of the Lipid Association of India, how do you assess India's current position in the global fight against hypertension? Additionally, if you could share any key initiative or strategies your leadership team is planning specifically for India to improve awareness on early detection and control of hypertension.
Thank you very much, Simran. Good afternoon, everyone. I'm really happy to get associated with experts here who are going to be probably discussing various issues pertaining to hypertension. I need to tell you something about hypertension this afternoon because we are all commemorating the World Hypertension Day. All of us know that we have completed nearly 20 years of this sort of commemoration of World Hypertension Day to create awareness in the minds of people who work together, particularly the healthcare providers and the paramedics, to join hands to prevent the onset of hypertension, to prevent complications and management of hypertension. All those aspects of hypertension are probably were focused in the past and continue to get focused even now. I must tell you that hypertension is a major risk factor for cardiovascular morbidity and mortality. Uncontrolled hypertension leads to stroke, heart failure, heart attacks, renal failure. It is not uncommon to see emergency complications like dissection of aorta and atrial fibrillation. It's unfortunate to see some patients getting into problems of peripheral arterial disease in association with hypertension. In addition, one should not think about anything else other than the dementia in those people in whom you have an uncontrolled hypertension, particularly even in the middle-aged group. Because sometimes middle-aged people seek advice for forgetfulness. If you just look at the blood pressure is on the higher side. If you are able to control the blood pressure properly, the dementia can be reversed. As and when the patient seeks advice, it is possible to do that at the stage when we see uncontrolled hypertension in the beginning. So earlier treatment is the most important thing. In addition, I would like to tell you that globally, the prevalence of hypertension is nearly about 30% approximately. In our country, the studies have indicated it's about 31% and 32% in females and 31% in males, and the overall percentage of the prevalence of hypertension is about 31%. In addition, I need to tell you that the most recent data that was published from our country, it is ICMR-India study, which had revealed the prevalence of hypertension as about 35.5%. And that was taken into consideration mainly based on the threshold beyond which we make a diagnosis of hypertension. 140/90 was considered as a parameter to diagnose hypertension in this particular study. If the same thing had been done with 130/80, which is recommended by ACCH guidelines, probably the numbers will jump to amazing figures. Nearly about 68% of the people in our country seem to be suffering from hypertension. That is a burden of the problem, not only encountered by individuals, not only encountered by families, it is encountered by the entire nation. So we need to realize that the prevalence of hypertension is almost equal to the prevalence of the hypertension that is witnessed globally. So that is again another important thing what I thought I should mention. In fact, many studies have clearly shown that the problem of uncontrolled hypertension exists in every country, maybe due to the non-adherence. The doctor probably prescribes the treatment and the patient is not able to continue long-term adherence. The long-term adherence, in fact, studies have shown at the end of 1 year, 42% of the people stop taking medications. 44% of the people stop taking medication at the end of 10 years also. So it's not uncommon to see patients don't comply with the treatment what is being prescribed by the doctor. In addition, I think the basic problem that faced by an individual doctor in our country is that they are not able to screen the patients for proper diagnosis of hypertension. That is because the outpatient numbers are something which we cannot even imagine in a government hospital. You cannot probably do the same way what is being described by many academic bodies to measure the blood pressure. Still, in government hospitals, the mercurial manometers are being used, which is actually abandoned, which should not be banned now. So we need to probably emphasize the important information that semi-automated oscillometric methods of examination by using the manometers probably will help us to understand better about the hypertension. One has to take the three readings, first reading omitted, the average of the two readings. If you can take it, probably that is the blood pressure of that individual during that particular time. The same methodology need to be adopted by the patient, by the relatives, even at home when they are taking the methods of examining the blood pressure. Only then it is possible to have a good correlation with respect to office blood pressure. One office reading of a high blood pressure does not mean that the patient has got high blood pressure. He has to probably get a good amount of communication from the doctor who is going to treat on him, saying that the doctor probably will insist on a home blood pressure monitoring, which is a must for everyone now because people are ready to spend for glucometer, buying a glucometer for testing the blood sugar. I don't know why our people are still hesitating to buy a cheaper mission, which can probably give them a better idea of our blood pressure. When you check the blood pressure in the office, it may be higher or it may be lower, but it can be go to the higher level or the lower level when somebody goes home. I think these are all things, facts known to every one of us when we are tackling patients. So the home blood pressure monitoring, if the record is brought by a patient for about a week's reading, which will give us an idea both morning and evening, and if you are able to see what is the variation, whether the blood pressure is on the higher side or not, that gives you an indication that the patient has got blood pressure. So we can ask me what's the best way of doing or confirming the diagnosis of hypertension. The best method is to submit the patient for an ambulatory blood pressure monitoring. That is probably considered now as a gold standard. Every patient has to be submitted for the ambulatory blood pressure monitoring at least once in his lifetime when he has a problem of hypertension. Even if it is not possible to do it at the time when the patient seeks advice, at least at one part of the time, he may require it to diagnose the nighttime increase in the blood pressure, to diagnose the early morning surge in the blood pressure, to diagnose autonomic dysfunction in patients with hypertension, to diagnose people with diabetes when they have an increase in the diastolic blood pressure and systolic blood pressure during nighttime, which are directly correlating with the increased mortality in this subpopulation. I think these are the points which probably cross my mind when you ask me to talk about the ways in which we can manage people with hypertension. As far as the doctors are concerned, they should, of course, I'm not telling that they are not trained properly to take blood pressure. Everybody knows to take the blood pressure, but they must know the best way of doing it, the best way of probably educating the patient, the best way of educating the relatives, how best they can do it at home so that they can bring a chapter or what I can say, a paper indicating the readings, which will help the doctor to identify. But allow the patient not to change the dose of the drugs. If he has been prescribed as a doctor by one pill, two pills, or three pills, he cannot change the dose of the drug based on the blood pressure reading at home. So there's so many messages that need to be probably taken into consideration not only by the healthcare provider, but when he has an interaction with the patient or the relatives, he should probably explain all these problems, the pitfalls in the diagnosis, the way in which we can manage hypertension. So the best way of managing hypertension is not only in the hands of the healthcare provider, but it is in the hands of the paramedics. So you must probably rely on the support that is being rendered by paramedics, particularly the nursing staff, the paramedics like your pharmacist or the health worker who is going to remote villages where they are able to do it. As far as the pharmacotherapy is concerned, very simple to treat hypertension, not like diabetes, where you have number of drugs. You have very few drugs, but still they are very, very good drugs, safe drugs, efficacious drugs. If it is used properly, the so-called uncontrolled hypertension, more than 1 billion people are suffering from uncontrolled hypertension globally. If that is understood by the healthcare provider, if he prescribes a good amount of drugs for the patient to get the blood pressure under control, it is possible to probably save tens of millions of lives today. So that is the message what I thought I should give it. We should have, we should be committed. We should be aggressive to diagnose hypertension at the early stage, to treat the hypertension at the early stage, and treat the hypertension to reach the goal at the early stage. These are the things, if we are followed by healthcare provider, I am sure the patients will not get into problems of stroke, problems of heart attack, problems of renal failure. The whole burden on the individual can be brought down. The whole burden on the family can be brought down. The whole burden on the government can be brought down. The government is unnecessarily spending money on those issues of screening, and then treating stroke patients, treating heart attack patients. If they're able to divert their attention basically on the basic parameters of identifying, screening, early period, and if they're able to treat it aggressively, I think it is possible. In fact, I need to tell you that the Tamil Nadu government had come out with a program called Makkalai Thedi Maruthuvam. This is in Tamil. You go to their doorsteps and try to deliver the drugs. For example, they check the blood sugar by CBG, capillary blood sugar, then they give the treatment. The blood pressure examination done by the manometers, and then they are given the medications. So free medications given by the government that should be adopted by every state in our country to make the lives of those people who suffer from hypertension. I think probably the Tamil Nadu is the one state where things had been adopted in a perfect way as far as my knowledge goes. I think if it is adopted throughout the country, the burden of hypertension will definitely be brought down. Thank you very much for giving me this opportunity. This is a message that I thought I should share it with not only the panelists who are here, but at the same time for those people who are listening to this video. Thank you very much.
Definitely, sir. Thank you so much. It is very informative for not for us, even for the audience as well. Because with these panel discussions with such important topic, we aim to raise awareness for our public so that they become informed, they take care of their health. And like you said, hypertension is the root cause. It starts from hypertension and leads to heart failure and stroke and many other issues. But if we take control of our blood pressure, we monitor it regularly, I don't think we land up onto a problem where we have to go for such bigger scans, such bigger, health issues. So it's time to take action on our blood pressure. We should public should start monitoring it on regular basis. And thank you so much for sharing your views and insights with us. It is very important for all our audience to understand and take charge of their health. Thank you so much for your presence as well, sir. It's an
I
honor to
hope you
have
would
you.
excuse me because I need to go to the other part of the city where I need to attend another meeting. So nice. Dr.
Definitely,
Vasanth
sir.
Kumar is also joining me. I need to meet him also. So nice. Thank you very much again for giving me this excellent opportunity to share my views about hypertension. Thank you.
Fine. Thank you so much, sir. Thank you.
Thank you.
So, as Dr. Narasingan also explained us about the importance of why this monitoring is essential, I would come to Dr. Vasanth Kumar. Sir, from your clinical experience, how prevalent is undiagnosed hypertension among the adult population in India, and what are the key warning signs that often go unnoticed?
Thank you, Simran. Dr. Narasingan had beautifully explained the whole situation related to hypertension. As it is, when you talk about undiagnosed hypertension, it's highly prevalent amongst all people. And when we are talking about the older people, geriatric people, that means we are generally referring to people who are above 65. We are a huge country with 1.4 billion people, and the population of elderly is also slowly increasing, almost to the extent of 20% in the next couple of years. Also, remember, it's a huge socioeconomic issue for our country. We have still 70% of them living in rural areas, and many of them are poor, whether they are urban poor or rural poor. As Dr. Narasimhan said, a lot of them depend on the government hospitals, whether you're talking about the primary health center, district hospitals, or teaching hospitals. And also, socially, these are, one becomes elder, they also can be ignored, or they are not being given proper treatment or taken to a hospital by the kith and kin of the family. You know that. And there is also gender difference. All these issues are there. So coming back to the issue, many of them may not have symptoms. Many of them have not even checked the blood pressure. Because what happened, they go to a primary health center or to a GP in hurry for a fever, and every person who walks into any center should get the blood pressure checked up at least once. I'm not talking about ambulatory blood pressure, I'm talking about this and that. I'm talking about the simplest mean of checking blood pressure. If it is high, check it again after some time. That is also not happening because, as Dr. Narasimhan said, there's a huge number of patients waiting everywhere. But then it's also very important. We should also sensitize the government, all the practitioners and paramedics about the importance of checking the blood pressure of anybody who walks into the clinic, especially the old. To answer your question, there are many older people who are undiagnosed, but they have high blood pressure. And when it comes to managing them, one is the detection. Managing them also is not going to be a simple matter, because what happens, you need to balance them. You also make sure that their blood pressures don't fall down, and also check the blood pressure once in a way. It doesn't again happen. So you need the doctors have to be very cautious. They can't give higher doses. They can't give too many antihypertensives. Maybe start with 1 and 2. Their blood pressure falls down, which can be also risky. So if you look at all these, it's not as simple as one thinks about managing hypertension, detecting hypertension, which is of course very important. If we do that, we are drastically going to reduce the cardiovascular as well as the brain complications in these individuals. We will save the time of the medical profession so that you attend to somebody, and you also provide them a better future. And also remember, these are the people who are depending on the youngsters, and that is what happens. So finally, we have to sensitize the government to see that how our primary health centers become sensitive to this issue of hypertension, where we plan and train the paramedics so that they would do a right job in the time that is given to them. We understand that they cannot give too much of time. There are too many people. But under the circumstances, I'm not even talking about international guidelines. I'm not talking about checking blood pressure many times. I'm talking about the minimal thing that one can be given, yet achieve the target of reducing some of these complications. So finally, it comes to sensitizing the people. So they need to get the blood pressure, sensitizing the government, sensitizing my own profession, so that we look at it more seriously and try to manage them. So I would like to be brief and I would listen to the other panelists. Thank you, Simran.
Thank you so much, sir. And now I would like to ask my next question to Dr. P. Ganeshkumar. So, based on ICMR's epidemiological data, how has the burden of hypertension shifted across urban and rural India in the last decade?
Sure. Thanks for that question, Ms. Simran. In line with my previous speakers and panelists, I wanted to bring some of the primary data which we had collected through our India Hypertension Control Initiative. When we say burden, it's highly varied, both urban, rural, as well as across the states. The prevalence overall, based on our national NCD monitoring survey, what we have observed is around 30% is the prevalence which is coming up. But we don't see any kind of like a major difference between urban and rural area. It's a very modest difference. It goes lowest up to 25%, and even it has gone to highest up to 34%. So that's a kind of like a burden that we do have. Overall, if you see India, there are nearly 22 crore people with the hypertension, 220 million. Apparently, of this 22 crore, only 1/10 of them are aware of that and they are under the treatment. But there is a huge interstate difference and there is huge urban-rural difference into that. Based on our primary data, what we have seen is that the urban-rural differences are very striking. The unaware hypertension has gone even up to 80% in some of the rural areas and states, and it has gone much lower to the extent of 40%. So in an average, we could say that unaware hypertension is around 60 to 70% across the country. And there is a huge difference into that. What does that mean? Which means that the rest of them who are aware, we need to know that whether they are under treatment or not. This we call as cascade. The 60% who are unaware, if I say average of that, will land up into complications such as heart attack and stroke. And they carry for long period of time. And even though we initiate therapy and identify them at the last, it's very difficult to manage them with a single drug. Then the cost of treating the patient is very, very high in public health terms. So every year there are nearly 2.5 million cardiovascular deaths, which are premature deaths occurring in India every year. And the number one cause is high blood pressure. Even one recent publication, when it is looked upon the young deaths, high systolic blood pressure is the number one risk factor for young deaths less than 50 years of age. So this is a very important critical condition. The burden comes on three things. Number one, high proportion of unawareness. Number two, even though they are aware, they are not put under treatment. Number three, there is a high uncontrolled hypertension. So it comes as high as that the control rate is very much low, even up to 5%. And it has even a best state, what we have observed based on our primary data is only 25% as a control. So this is the kind of numbers that we do have. Even in a best cell system state, that 75% of uncontrolled means, then we could see overall, if you in a country like India, if I apply the same proportion, out of 2.2, out of 22 crore people, only 2 crore of them are actually under control. Nearly 20 crore are uncontrolled. So that's the kind of numbers we are talking about. I will listen to the other panelists and more comments on that.
So, and I think that's a huge number what we are talking about, and a lot more of awareness is required. So, in terms of nutrition, I would like to come to Dr. Jagmeet. Ma'am, from a nutrition science perspective, what dietary trends in India are contributing most to the rise of hypertension cases, especially among the youth nowadays?
So thank you, Simran, first of all, for giving me this opportunity. And to my mind, I think nutritionists are one of the very important stakeholders in the management of hypertension. Uh, to begin with, I will make two statements which I truly believe in. One is looks can be deceptive, and two, that preventive nutrition is far more stronger than curative nutrition. So, why I made that first statement, looks can be deceptive, because very often, people think they are normal. They are, there's nothing wrong with them. But like what Dr. Ganesh said, hypertension pretty much goes undiagnosed for a long, long time. And I think that is where regular health checkups, screening, I think these kind of endeavors really come into play and are very, very handy. And secondly, like today, as a nutritionist, I think for me, my first step to manage hypertension would be diet and lifestyle. And it is absolutely documented, published, that if we can achieve, wherever I may be in my life, I can achieve a 5 to 10% weight loss. And if I can get, quality eating, in my dietary pattern, I will be in a position to manage hypertension. Now, let me make this statement. You said young adults. We recently did a randomized controlled trial in the city of Mumbai, and we screened, youngsters from the age group of 16 to 25 years. You will be shocked to know that 30% of them were pre-diabetics, and ironically, majority of them were normal BMI or slightly low BMI. So, but when we looked at their dietary pattern, what we found was a high consumption of high fat, salt, sugar foods. So, one of the most important culprits which has really laden this country is an increased consumption of HFSS foods. And sometimes, this load of sodium comes in such a deceiving manner. Maybe it's a part of additives, though it's there on the label, but people do not pay attention to, maybe they are consuming a packet of chips, but they're adding 200 milligrams of sodium, through that. So one is the increased consumption of HFSS food. And let me share that when we looked at the dietary pattern of this population, which we surveyed in Mumbai, 80% of them were consuming HFSS food on daily basis, and 30% of them were consuming ultra processed foods on daily basis. And these were not kids coming from higher socioeconomic strata. They were coming from lower and, middle socioeconomic strata. So as far as youth is concerned, there is no concept of meals. The concept of eating for a youth today or a young adult today is snacking, and they are heavily dependent on outside food. And let me make another statement, that high dependence on restaurant food is another very important source of additional or excess sodium. Not only sodium, more amount of fat, and absolutely no fiber coming from those kind of foods. So these are two trends, which have rampantly impacted the young adults. And why I say, because it is, food is not a priority for them. Maybe they are ambitious, they want to achieve their targets in terms of their profession, but somewhere, and like I said, looks can be deceptive. They don't feel there's anything wrong with them, and
Yeah.
probably they may be having hypertension which goes undetected for a long time. And these kids whom we these are the young adults whom we interacted with, they were not even aware, and they had a high level of inflammation in the body. So the IL-6 levels were high, they had hyperinsulinemia. So what is going inside your body, sometimes you're not even aware. So these two trends are very, very significant. And with a lot of women going out to work, there is huge dependence on someone else cooking for you, or you calling food from outside, or eating outside. And let me tell you, this is not only an urban scenario. I recently visited a tribal area, and I could see the presence of these HFSS foods, the sugar sweetened drinks, and the desire of people to eat more, and the huge number of Chinese joints and whatever joints you can say, this is I'm talking about in a tribal area. We really need to like take guard on the situation where we are getting into, where somehow, especially youngsters, are not, really prioritizing the quality of what they are eating, and they are falling prey to high intake of salt, high intake of fat, more of sat fat or trans fat, and high intake of added sugars. And that's where, I mean, hypertension doesn't come by itself. I mean, that's just the beginning of the story. I mean, it's always, a cluster of things which get manifested and what we call as the metabolic syndrome. So I think these are some of the things which I'd like to highlight. Yeah.
I would agree to this, ma'am, because I also come under of the category which we were just speaking about, the adult youth specifically. And yes, it is nowadays lifestyle are more dependent upon the packed food, that the food which has more of sodium, sugar, and everything, because I think that is more easily available. And like you said, people are now more on to focused on their career, the profession, and it is not about eating healthy; it is more about snacking. So they just grab something, have it quickly, and then they work on their, whatever targets are being given. So I think yes, that culture is everywhere nowadays, whether it is urban or rural area. But we'll be coming back to that and speaking more into that. But now my question is to Dr. Vasanth. So what challenges do clinicians face in ensuring long-term treatment adherence among hypertensive patients, especially the elderly people?
Simran, I just wanted to get the question again. You wanted to know how to ensure that the long-term treatment continues in the hypertensives? Was it
Yes,
that
sir.
question?
Especially the elderly people. Yes, sir.
Yes. So actually, it's quite a challenge to do that, because what happens, one thing is it's always connected with monitoring the blood pressure also, because the dosage can be changed in many times. And as I earlier said, we cannot afford to have somebody with hypotension also, nor with uncontrolled hypertension. So in this situation, and then many of the people, like Madam was also telling, lower socioeconomic people's bad eating habits, hypertension is even more common amongst them. And then the amount of literacy they have is a question mark. So we need to emphasize about the importance of taking the medication regularly. So many times they skip the tablet. And also it is also coupled with checking the blood pressure once in a way. They won't be able to check at home. They won't be able to uh, visit hospital very often, but they need to check as much as possible, so that the doctor has an advantage of titrating the dose of the medication. So finally, it's one of the important aspects. One thing is you want to prevent the disease. You want everybody. I mean, Dr. Ganesh mentioned how severe the incidence is. So all the people above the age of 30 in our country should get their blood pressure done at least twice a year. And those who are found to have high blood pressure, they need to be monitored more often. They need to be on medication right from the day one. And Madam has explained about the importance of nutrition, which is very, very important. People are eating bad food, junk food, food with a lot of salty food, and also a lot of trans fats. And there is an association between obesity, diabetes, metabolic diseases, hypertension, as she mentioned. So we need to attend this also while treating these patients. So the long-term medication, uninterrupted medication, appropriate medication, all of them are important, and which is not going to be an easy thing, but we need to work on that. Yeah, that's it, Simran.
Thank you, Dr. Vasant. And yes, once a patient has been diagnosed with hypertension, it is mandatory for them to, monitor it, to keep that device at your home and the medicines at your pocket or in your bag. So immediately you can take action if something is, problematic there. And as I know a little bit of about this, as I come from a family of my elders having this hypertension issue, they have learned this thing. Once you have been prescribed by the medication of hypertension, you cannot skip it. You have to regularize it in your routine. So I think this is something non-negotiable. Correct me if I'm wrong, Dr. Vasanth.
Yeah, you're right. So most of the times they need medication, which you can actually call it lifelong. Nobody likes to hear that point from the doctor saying that, how can I be hooked on for something for lifelong? But then it's important. Only then you can reduce the complications which are mentioned by my panelists. And then another point about it is even monitoring once in a way is important with the titration of the dose. So two things we have to tell all the people, whether they're old or young. You should not stop the medication. You should check the blood pressure once in a way and see whether the dosage has to be adjusted. These two things are absolutely non-negotiable. Only then we are effectively handling this huge issue called hypertension, thus reducing some of these major side effects, major complications on the brain, kidney, and heart.
Very rightly said, sir. It impacts the other organs as well and lead to other major serious issues. Moving on to my next question, Dr. P. Ganeshkumar. Sir, how do socio-economic factors in healthcare access disparities affect hypertension detection and control across various Indian states?
Thanks for this important question, and I thank the panelist for bringing a lot of insight on this an important day. Uh, Based on our primary data under India Hypertension Control Initiative, we did a baseline survey at the community level across 10 districts covering nearly 4 lakh individuals, and as well as follow-up survey recently we have completed. And there were huge important insights that we have drawn upon. With respect to the socioeconomic disparities, definitely there is a huge difference in terms of accessibility towards the treatment, which is differing between the both urban and rural area. But apparently, this being there are a lot of initiatives have recently happened by many governments, including the state governments. For example, by the Indian government's initiative by Health and Wellness Center under Ayushman Arogya Mandirs, it goes the hypertension care closer towards the community. The state government initiatives, like one example mentioned by Dr. Narasingan on the Tamil Nadu government's initiative, taking the drugs towards the doorsteps, are all actually bridging this particular gap, doing this last mile connectivity of taking the treatment closer towards the community. But apparently, initiation is not a bigger deal. Of course, it is an issue. The most important, clearly, Dr. Vasanth also has mentioned, is adherence towards the medication. Since this is a chronic care disease, we need to understand differing from any other disease. Both hypertension and diabetes is very unique. It's a chronic care disease. It's a chronic care model. We need to continually put on them treatment continuously and titrate them based on their uncontrolled status. Our primary data are not actually promising in terms of it. We call this as a kind of like the bridging gap, which means they are aware but not treated. There are certain group of individuals aware, treated, but not as per protocol. And there are other group of people who are aware and untreated and uncontrolled. So this goes on. What we have seen in terms of realistic numbers in some of the districts which are predominantly rural, what we have observed, this treatment gap among the unaware, nearly 30% of them are not treated. And this, even in a best implemented districts and state where the health systems are strong, the gap is nearly 20%. Despite they are aware, the untreated goes, even in a best available state, it's going about 20 to 30%. This is very, very huge. Unless they are not, this particular gap is not filled, it's very difficult for us to put them continuously on treatment. So we call this as a cascades of the care. And since it's a chronic care model, it has multiple factors to put forth together. Very specifically, there are patient specific factors, not just goes along with an awareness, continuous monitoring. To health system, we need to have drugs. One of the major issue what we have seen in across both in urban and rural area, the most important issue are drugs. We have been calling about unaware hypertension. The other issue here is aware. Patients are coming to the hospital, but drugs are not available for that. I'm talking about the many of the public health sector where it is challenging the numbers are increasing. And the other side of that is that currently in hypertension, the best part when compared to diabetes is drugs very efficacious, cost effective, and it is cheaper. So these drugs are available elsewhere in private sector, whereas in government sector, it's very difficult to do the last mile connectivity. So with all these multiple challenges, the clear-cutly we could see from our data that there is a lot of socioeconomic factors and healthcare disparities. But there is no major difference what we have seen across the gender. There is no major difference what we have seen across the age group. If the same behavior is having a little bit of higher proportion in the younger age group, the elder age group were having a better control when compared to the younger age group. In terms of gender, females are under better control when compared to male. So this is the thing what we are seeing on the ground.
Thank you so much for shedding light on that difference when it comes to adult or the younger people and male and the women population in our country. Uh, as we know that elder people have better control, but younger people needs to learn that. And I believe, as like I mentioned earlier, I come from a family of where my grandparents, my parents have a history of hypertension. So I'm little bit concerned that I need to keep my blood sugars, my blood pressure into control, as there are higher chances of me falling into that category. So I think these little bit kind of awareness helps in a long way, to make people more educated and aware of in these areas. So I think once they get to know how badly it can affect them, they will learn this, and they will also have a better control over their health and uh, what to eat and what not to eat. As we have come to this segment, I would like to ask Dr. Jagmeet, ma'am, how important is personalized diet counseling in hypertension management? And what challenges do dietitians face in implementing these at scale? Because if we are targeting younger population nowadays more, as the cases are being, getting more in younger age group, the options available to them in the market is more of the packed food rather than a healthy option. So how can we manage this challenge also?
Okay. So I think an excellent question. See, it's very important for all of us to understand that the closer we are to the natural foods, we are never worried about excess sodium. If you are, eating your normal diet, which is your traditional diet, and you are consuming most of the foods in their natural forms, I guarantee you will probably never have excess sodium intake. Excess sodium intake comes only from added salt, and that added salt comes in so many forms, disguised forms through these ready to eat foods or snacking items, or uh, people in India are, by virtue of being, their traditional heritage, they are wanting to have papads, pickles, chutneys, whatever. So what I'm trying to say is that if, as a nutritionist, what in a generic statement I would like to make is, whatever age group I may be in, if I make an effort to be closer to my natural food intake on a scale of 100, maybe 7 to 8 is my natural food, and all of us have sometime foods, so your sodium laden foods should never become your everyday food. If they are becoming your everyday food, you are entering a problem. Now, the second point which I want to make here is that today we start worrying about sodium right from the stage when we are weaning a child, right?
Yeah.
So today, as mothers, we recommend the mothers not to introduce salt and sugar at least till the age of 2 years, because development of taste buds happen right at that age. So
Hmm.
if we are very careful in terms of exposing the child to different flavors, variety of foods, in a desired format, you will see that the child will never develop that craving for salty foods or the craving for sweet things. We say sweet tooth. Sweet tooth and this salty, these are all conditioning, which we develop very early in our age. And I think we are responsible ourselves how we bring up our children. That is one. The second thing is that as so far as personalized nutrition is concerned, uh, that's the order of the day, because again, as a nutritionist, I would say one size doesn't fit all, because all of us are different. We have different body composition, we have different environments, we have different occupational challenges, we have different resources. So I can be generic in some things, as like my generic statement could be as close to natural foods, but my
Yes.
specific statement would be that how do I customize the diet so that you achieve the basic goals which a nutritionist would have dealing with a hypertensive patient. Like I said, my first take would be that I would not go closer to the drug. First is I'd like to prevent, person getting hypertension. So the genesis of hypertension is accumulation of fat in the body. And like I said, we are lean obese people. We may not look fat, but we are carrying a lot of fat inside our body, and especially around the waist. So the only way to get rid of, excess fat at that stage is good quality eating and high levels of physical activity. So these are generic statements, right? But then when it comes to somebody who has got hypertension, my success story would be that he should not be increasing his dosage of drugs to maintain the blood pressure, right? He should be stabilizing his dose, and if possible, in consultation with a cardiologist, he should be bringing down the dosage. And that's possible provided I customize a diet to make sure that he's achieving 5 to 10% fat loss, not only weight loss, fat loss, and just by quality eating. What do I mean by quality eating? So if my diet is high in dietary fiber, and we have huge array of seasonal, local, colored vegetables and fruits, if half of my plate is vegetables and fruits, I have protein in my plate, and I have restricted quantity of carbohydrate, and I'm adding good quality fats through nuts and seeds. Like, in a sense, this is giving me quality nutrition. But if you see, heritage or culturally, you will see, I mean, I went to this tribal area, and whenever I was served food, there was a bowl full of salt which came along with the thali. So people are so used to not not only just having salt in their food, but adding additional salt there. So like I said, if natural foods will not give you excess sodium, it's only the way you treat the food and how you add these kind of things in your diet, that it keeps on increasing the load of sodium in your diets. So, and another point which I want to make here is, when you spoke about personalized nutrition, I think we also need to have a conversation with our patients about what are the long term effects of these medications which they take, for years together. I mean, you meet patients, they're having hypertensive drug for 25 years, 30 years, but they need to be educated that if you are taking some of these medications, these are the parameters which you need to monitor regularly, so that you're doing a damage control side by side. So I think these are some of my thoughts for this, and I'd like to hear others. Yeah, thank you.
Thank you so much, Dr. Jagmeet. You have pointed out some very good points, and it has been very educational for our listeners out there also. So now, as we are moving close to our end, I'll be asking the final questions to all my panelists. Dr. Vasanth, are there any recent clinical innovations or treatment protocols you see as game changers in the hypertension management?
Hypertension management, as Dr. Ganesh also was explaining, fortunately, we have safer drugs now, which can be managed. We can give them to the people. There are about 3, 4 of them. If you really look back, 40 years back, we used to have 2 or 3 drugs like risapine, hydralazine, methyl dopa. Those were 3 drugs we used to use. They had side effects. They were not very effective. Now we have simple 3 or 4 drugs, not very expensive, are very safe as long as the dosage is adjusted. And finally, monitoring is important, but monitoring is something which is individualized. Depends on the person whom you are handling. There's somebody who is an urban person, who is affordable. Why not we have home monitoring more often? For the research work, the tool is, of course, doing the continuous blood pressure monitoring. Otherwise, in the rural areas, we need to train our doctors and paramedics to check the blood pressure, have more blood pressures which are in working condition, so that they check it properly. Because finally, it all depends on how effectively how they check the blood pressure. Giving medication sometimes is easier than monitoring, and telling the patient. As you said, finally, we have to prevent. Everybody should get the BP checked up from the age of 30. If they have BP, they need to check it more often. They need to take medication, follow the diet and nutrition, which is very, very important. Healthy lifestyle, apart from the healthy diet, and avoiding the bad habits. Smoking can be dangerous, alcohol can be dangerous, which actually increase all the metabolic diseases, including hypertension. So I think this is the message that should go down to all the audience who have been listening to us, Simran.
Thank you so much, Dr. Vasanth, for sharing your views on this, how we can monitor and take control of this. Dr. Ganesh, can you share insight into ongoing or upcoming ICMR initiative focused on hypertension prevention and control? Although you have already answered about India Hypertension Control Initiative, but if you can let us know more about it.
Yeah, I'll be very brief. India Hypertension Control Initiative is a joint initiative by ICMR, Government of India, Ministry of Health and Family Welfare, WHO India, and the Resolve to Save Lives, and most importantly, the state governments. We started in 2017 with an humble beginning of 5 states and 26 districts, and now it is currently being implemented in 156 districts in across 26 states. Nearly 5.1 million hypertension patients and 2.6 diabetes patients are treated under this particular IHCI. And in IHCI, the most important thing, it is mainly based on a package called WHO HOTS package. These are strategies to improve the hypertension management at the primary care. The most important are, number one is linear protocol, which means it's a stepwise protocol. 3 drugs, which are very much cheaper, available, and we made state-specific protocols across these 26 states. Number two, uninterrupted supply of drugs till the last mile connectivity. Third, patient-centric care, which means that the patients, even when they go to health and wellness center, they need to receive good quality treatment for hypertension. Fourth is task sharing across the healthcare workers. Everyone will be trained in an health center, so anyone can check the blood pressure and anyone can identify with a high blood pressure and refer to a physician to get this treatment done. Now, currently, we do have telemedicine services, so anywhere else this treatment can be initiated. The finally is most important. The burden is very high, numbers are very high. So information system is the fifth one. Without a robust information system, it's very difficult to do and scale up an hypertension. These are the things which we have demonstrated in India Hypertension Control Initiative. Continuing to do that, these learnings were converted into an online course. Now currently it is being done, and we are going to do and catch them young. The MBBS students will be taught through the community medicine departments on hypertension management as a modular training, and as well as will be rolled out along with many professional societies as a free online course of ICMR for physicians. And we are also having SALT initiative called Project Namak, which specifically targets on importance of less salt reduction and introducing that nursing-led counseling for salt reduction. Our trials have seen to be very promising. We are highly pushing this as a most important public health initiative. These are the things which is coming up, and we are building a lot of data on the understanding of the determinants of the control of hypertension, and as well as what are all the most important critical outcomes where we could catch them young. These are the things which is going on.
Thank you, Dr. Ganeshkumar, for answering that question and giving us insight about this initiative, because I believe slowly and gradually, because of this initiative being transferred to all the healthcare system and to the patients, and how people are getting aware about their healthcare, slowly and gradually they're taking charge of it, and it is making a bit of difference, and it will make a bigger difference in the coming years. We can see, and when we believe in that. So thank you so much for sharing that initiative with us and the steps taken in that.
Thank you.
Dr. Jagmeet, how can food labeling, salt reduction policies, dietary awareness campaigns be strengthened as part of national strategy?
Yeah, thank you, Simran, for that question. And I think before I answer this question, maybe I'd like to make one submission to Dr. Ganesh, because he's from ICMR and he's doing such brilliant projects. Sir, my submission to you is, to my mind, whatever verticals we have created in the healthcare, and we have increased our reach in the states, please create a strong vertical of nutrition alongside. It should be, starting from a grassroots level till, whatever be the higher hierarchy of the healthcare system. At every step there should be a trained nutrition professional available, because what I feel is, that there is immense need for, dissemination of the nutrition related information, and that needs to be customized to what is locally available. What are their dietary patterns? It cannot be a generic statement. It has to be, like one on one kind of a conversation, being with them for a long time. Then only we can see a behavior change happening. So this is my submission and request, as a national president of IDA. And I'm also the member of the National Allied Healthcare Professional Council as a nutrition expert. So, I can see that there's a huge opportunity where we can get, the nutrition professional woven into the healthcare team, in the entire ladder. It will make a lot of difference, in terms of the impact of whatever efforts we are doing. I think government is doing brilliant work, and ICMR also, is the reach, what you said, from 6 states. Today you've reached 26 states. But if with this we strengthen the nutrition vertical also, it will be really more impactful. This is what, my submission to, Dr. Vasanth, Dr. Ganesh.
Thank you, ma'am.
Okay, yeah. Coming back to, Simran, you spoke about the initiatives. So I've been on the expert panel of FOPNL, the front of pack labeling, and we've had huge deliberations on that. And I think the major crux of what needs to be disseminated to people is what I said, HFSS. People are still not aware that it's mandatory for any food which is packaged to declare the sodium content, to declare the added sugar, to declare the sat fat, the total fat, trans fat. But somehow that literacy has to come in, and people need to see what they are picking up and what they are consuming, and how we can make these labels more user friendly. I think that's also a mandate, so that, we simplify things. We don't make things complicated for people, and they just get to know that this is something which I can take some time, but if I make it every day, it's going to create problem. Now, FSSAI, I was a part of the initiative, what we call as Net Profan. It's a network of professionals of nutrition, wherein 7 associations came together, and the idea of coming together was to talk the same language and to talk evidence-based, communication to people, so that they don't get misguided or misled by information, because today there is, like, there is, what should I say, tsunami of information available, and people are rather over informed than correctly informed. So that's where I feel, some of us, as key opinion leaders and some of professional associations have, they have really contributed a lot in the past. And still, I think NetProfan today in itself, has created so many resources, and they've done vernacular. So they're trying to reach the deep down each and every citizen of this country. And again, as a nutritionist, I feel nutrition literacy is the right of every citizen of this country. I think nutrition literacy only doesn't remain with a nutritionist. A nutritionist has to impart this nutrition literacy to every individual so that they are empowered to take the right decision. I mean, I cannot be with a person all the time, but if I empower the person to with information, with simple understanding as to what is right and what is not right, and like I was just mentioning, customizing it, talking the language he or she understands, bringing solutions which are practical in their environment. I think these are the endeavors which we really need, and we are working on it. We are at it. A lot of my fraternity is like today are on the social media. They are wanting to give messages in simple forms, just to create that right messages go in. But I would also congratulate FSSAI and Ministry of Health and Family Welfare, not only for NetProfan. I think they had a number of initiatives. One of them for sodium was Thoda Sa Kam. We started with an initiative called Thoda Sa Kam. So it had, Thoda Sa Kam namak, Thoda Sa Kam sugar, Thoda Sa Kam oil. So today we are talking this language that wherever you are, please bring your levels down. And we all know today, if I have to say that how much salt you should consume in a day, not more than half a teaspoon. It's like 2.5 grams per day. If I have to say how much oil you should consume, I can clearly say that your total oil consumption per month should not be more than 500 ml per person, in the family. So then similarly, sugar is like we are not recommending added sugar. We are saying if you can go without sugar, because sugar is naturally present in all your foods. So
Yes.
these are simple things. If we understand and take charge of ourselves and bring about lifestyle modification. And I think Dr. Vasanth pointed out about alcohol. Let me tell you, alcohol has creeped in a big way, not only in the urban environments, but in the rural and tribal environments as well. And what is happening is it's not only just a vice, but it is damaging their vital organs. It is pushing them towards more malnutrition, and are making them more diseased. So, like on one side, we want to strengthen the nutrition vertical. We want to talk about the drugs availability, early diagnosis. I think alcohol is something which also needs to be looked at very seriously, because it's creeping in at a very very early age, across urban, rural, tribal areas, across socioeconomic strata. And so these are some of the things which I felt I could contribute here.
Thank you, Dr. Jagmeet. All the points has been very informational and important for our audience, and I would like to thank each of the panelists present here for sharing their insights and views with us, the expert opinion they have shared, because it is very important for all of us to educate our public, to aware our public, so that they become this educated enough to take, so that they can take charge of their health, and they know what is right and what is wrong for their health, when to consult a doctor, when to how much regular monitoring is important, how to manage their hypertension. And it is important for them to know what government are doing for their health. you know so much of efforts are being put in for this. So thank you so much for shedding light on such important topic and helping us to aware our public out there on this important day, which is World Hypertension Day. So thank you all the panelists for taking out time out of their busy schedule and coming to the platform for this important cause. It means a lot for us.
Thank you,
Thank you.
Simran. I'm sure this
Thank
message will
you.
reach everybody. Thank
Yeah,
you.
thank you. Thank you. I think it was a very fruitful discussion. Thank you so much.
Yes, ma'am. Thank you so much.